From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
Welcome to this edition of Inside the 1581. You just saw a video that we produced here at OHA to kind of explain a very unique program that the federal government created over 30 years ago, which is designed to support hospitals and federally qualified health centers to access very expensive medications at the lowest possible cost. And so that video, we've been using that as an organization to help educate the public about this very important program and what it means to ensure that our rural communities, and particularly our communities that offer very sophisticated services that require high-cost medications, to be able to do that cost-effectively. And so today we're going to talk about the 340B drug program. I'm your host, Rich Rasmussen, and I'm joined here with two of my colleagues who are leading healthcare organizations in their communities. And we're delighted to have joining us Trent Borland, who's the CEO of Cole County General Hospital. Trent, you've been on this before, haven't you? We had you back in November, didn't we?
Yeah, at OHA Connect, yes.
That's right. So we did have a chance to talk about that. And we're also delighted to have joining us Jay Johnson, who's the president and CEO of DRH Health in Duncan. And Jay, you haven't been on our show.
No, about time.
So this is the first time,
yes.
Yeah. And so we were just talking a minute ago on that opening video. Trent did indicated that it needed more cowbell. And we'll have to agree with you on that. It did need a little bit more cowbell. But 340B drug program, it's something that right now it's under attack in legislatures all across the country. And for our listeners, this program requires the pharmaceutical industry to make drugs available at its lowest possible cost. The hospitals purchase those medications. And because we purchase those medications at a very low cost, we're able to use those savings to be able to invest in very important, higher expensive services in a community, like cancer care and others. And so the drug industry is engaging in a very robust discrimination effort against those hospitals that are participating in the program. And so we have legislation in the state legislature, and we do appreciate lawmakers who understand the importance of this program, that are moving legislation along that would simply do one thing, and that is to prevent this discrimination. So we're going to set that issue aside and kind of talk about it, guys, with what this program means in our communities. And before we start, Jay, why don't you tell us a little bit about yourself, what got you in this, and about DRH Health, because you guys you have a pretty good footprint across Stevens County. And so tell us a little bit about your organization.
Sure. I've been at DRH Health for 15 years. We are two hospitals, Duncan Regional Hospital in Duncan and Jefferson County Hospital in Waurika. And we have 16 clinics in 5 counties in southwest Oklahoma. Most of those are primary care clinics that serve some of very rural parts of our region. And so a large reason we've been able to expand that has been the 340B drug program. It's been instrumental in us being able to expand and serve more people hopefully in areas that are closer to where they live. One of the things that's probably been the most significant use of this program has been how we've done our cancer program. We have a joint venture cancer centers throughout southwest Oklahoma. If you live there, you'll know it as the Cancer Centers of Southwest Oklahoma. And that's a joint venture between Comanche County Memorial Hospital in Lawton, Jackson County Memorial Hospital in Altus, and then Duncan Regional Hospital in Duncan. And the three of us, it's been in existence almost 20 years now, and significantly, the joint venture would have never happened without the 340B drug program, because those savings, and specifically the savings that are used for cancer treatment for those drugs are how the program survives. And so it's been significant. Obviously, you can honestly say there would not be cancer treatment in the entire quadrant of the state if it weren't for the 340B drug program.
And that's a really important part because of the challenge that someone who's struggling, with cancer. It's so important because the medical evidence will show that if you can receive your care closer to home, you have better outcomes.
That's right.
And it's really important. But you're kind of in this tweener community, right? With where you are. Whereas Trent, I've been to your hospital too. I love our small rural communities, and you're classic. When you think of a critical access hospital and you think of a very small community hospital, you're it. So tell us a little bit and remind folks about your organization.
Cole County General Hospital has been serving the communities in Cole County since 1948, and with the 340B savings, now we've been able to recruit a second doctor to our community, and now we're expanding care delivery to those, and then allowing us with that savings to get into enhancing our care coordination services and reducing that travel burden on citizens to have to outwardly migrate to receive care. And so and that's all done through the 340B savings that we have through our 3 primary care clinics associated with Cole County General Hospital.
So when we look at this, not every hospital qualifies, right? So you've got you have sole community providers, okay, and Jay, you fit that category.
Yes.
You have disproportionate share hospitals. So for our listeners who may understand, those are organizations that serve a disproportionate share of our low-income neighbors. And then we have critical access hospitals that are deemed eligible for that. And so you would think that because you are eligible for this program and you're following the rules, it'd be pretty easy to be able to make sure that your community has access to these medications. But we hear different stories from that. So let's start back with you, Trent, because I know I've heard from a number of our critical access hospitals, and I'll use the folks in Fairview as an example, where they have 2 community pharmacies, and the manufacturers will only work with one of those community pharmacies. So you have a situation where not only does the community lose out, but so do the pharmacists or the owners of the other retail pharmacy if they're being discriminated against and not allowed to participate.
Yeah, restrictions were placed that we could only contract with that one pharmacy. And so in Cole County, we have one, and they're our primary source partner for that. But across the state, like you're talking about with the critical accesses, we have 39 in our state that are, as you stated, are immediately eligible for this. And so they stretch from Boise City to Broken Bow and the most rural parts, remote parts of our state. And without that, you're either talking about a hospital cutting services or closing completely. And now we're talking about communities that no longer have that basic access to healthcare, no emergency room, no primary care, no inpatient beds, no swing bed services. And so that would be detrimental to our rural communities to lose that.
And we have a slide that we've used when we've spoken to our members and community gatherings of just the footprint of this program and how I think we just talked about earlier today. There's only one county in the entire state of Oklahoma that doesn't have a provider participating in 340B. So it is extensive. And maybe, Alex, on the video version of this, for those that are watching on YouTube, we can throw that image up of that slide. And so even our county health departments are utilizing 340B. So they in themselves, as taxpayers, right, we want to make sure that our county health departments have access to purchase these medications at the lowest cost possible. So the discrimination by Big Pharma actually has the potential of increasing costs for all of us as taxpayers, which we don't want to see happen either. So Jay, you have, Duncan as a rural PPS, you've got our critical access hospital, you've got clinics, rural healthcare clinics as well. Talk a little bit about how the system of care you've created in response to the needs in your community, how important it is of having pharmaceutical access within that system that you've created in your region.
Well, it's obviously incredibly important. Rural healthcare is really, at its fundamental level, a primary care office and a local pharmacy. I mean, that's really what's most important for to do fundamental primary care. And in these clinics, we're looking at some communities like Ryan and Velma and Ringling.
And how small? What population?
Those three communities each have less than 1,000 people in their communities.
And so they could have to drive an hour or so just to fill a prescription?
Probably at least 30 minutes.
Okay, and have access to lower cost medications and have access to the service that's created because of the savings that you're able to generate.
Yeah. And what we do with those savings is we can keep those clinics open. We take those savings and expand our OB services. And we do all the things for the amount of charity care we provide in our communities. The savings helps us fund those things.
And I think that's often overlooked when we think about that. So when you hear from your peers in our urban core, right, whether it's in Oklahoma City, Tulsa, Lawton, interestingly, is considered an urban community by the Census Bureau for us. This is an important program for them as well. So what have you picked up from your colleagues who have larger programs and their concerns over the potential loss or threats to the loss of 340B?
Yeah, for the critical access side of things, is we partner with those larger hospitals for things like telestroke and other cardiology based services. And without that 340B savings, maybe they have to reduce the services that they're offering, their community outreach that they're doing to our smaller rural communities. And so that even puts us at a greater disadvantage if we lose that. So, challenges are I think just never ending with if this goes away.
And that's a good point, right? So if you've got, let's use telestroke as an example. And so if you've got a large system, whether it's the OU system or SSM, Integris, or whomever, if they're supporting that rural community, there's a cost for not having enough patients, right? Because it's all about volume, have enough patients to spread the cost over it. So most folks would step back and say, why do you want to offer that service if you're going to lose money on it? Just close it. But we work differently in healthcare, right? Because we respond to human need and we look for ways to be able to make it work. So one way to make it work is because we can access medications at a lower level, we can take those savings to offset. So to your point, whether it's telestroke or teleradiology, any one of these rural communities would literally lose access to those services at home.
Yeah, definitely. I mean, when you touch on it, that's the Oklahoma standard. That's we come together to help others when they need it. And our larger systems reach back to our small communities and offer services that we otherwise couldn't offer. And now we're putting patients into larger or longer travel times, like you talk about. With providing care locally, we see greater impacts on health outcomes, positive impacts.
And you can say that as the chair of the quality committee for OHA. So you've seen this, and certainly you're working on a telestroke project as well. So let's just digress for 1 second. Tell us a little bit about this telestroke, because I think that is an example of where there's a partnership that has been developed that, again, not having the opportunities to offset costs in something that is potentially one in which you rub two nickels together, you only have one nickel, right? And so, but you guys are making it work, and 340B does provide opportunities to have that investment.
Definitely, because there is a cost sharing portion of that for us to enroll in. But the benefit that I see is I believe the number is 73% of strokes are unnecessarily transferred to a higher level of care, and we can now treat them in our hospital in push of a button within, I believe, on average 4 minutes. We have a board certified neurologist that is, on the other line, and now they're speaking to our care team to coordinate care for that patient, reviewing imaging results to say, yeah, we need to either get a helicopter on the way or warm up an ambulance to get that patient, or we can keep them observationally here in our community. And so now we can keep them in our community, so our less strain on the family in a critical time. We can administer the thrombolytics to them so that we can reduce any outcomes, negative outcomes. Because in a stroke, I think the word is, or the phrase is, time is brain, or minutes is brain. And so, without that quick intervention, then we risk long-term detrimental effects to patients, and we can care for them in our community. And now we reduce any, additional challenges on family to care for somebody who has long-term negative effects and possibly have to, reach out to long-term care communities for long-term placement for them because of inability to care in their local community. And then the other side of it is now our community sees the level of services that we're providing, and they become more confident in us, and we reduce our bypass factor that is eroding a lot of facilities because they say, well, they're just a Band-Aid station. I'm just going to drive up the road. In Jay's situation, I'm going to just drive from Waurika up to Duncan because it'll be better for us there. But what Jay's doing out there is a model, and now you can get that care right there in Jefferson County, and for us in Cole County, we can do that, and the other 37 other critical access communities in our state.
It's so important because when you think about a program like this, creating what I would call the seed corn to really grow a system of care in this state. And so, Jay, you guys have been involved in 340B. It is, as you indicated, part of the glue of what you're doing to ensure that you connect all of those pieces in the system that you've created. Tell us a little bit about the extensiveness of your 340B program, and then we'll get back into the cancer question after our break. But how that works, and you've got the pharmacy within the hospital, and you've got your clinics, and you've got your critical access hospital. How all of those are woven together, and how do you interface with the pharmacists or the drug retailers that are out there?
Sure, and because we do a lot of work with the independent.
Because it's partnerships, right?
Yeah, the independent pharmacies are partners for sure, and in all those communities. So we're in 5 counties with those 16 clinics. There are most all those communities have pharmacies also that we contract with, and so I should have pulled the number, but there's more pharmacies than clinics that we're contracted with that we work with to help create the savings from the 340B program. And you mentioned, I think, an important question too a minute ago about how this impacts our urban peers and what happens there. And in those communities, these are typically not your wealthiest facilities that benefit from the program. These are the places that, as you mentioned in your opening comments, take care of a disproportionate amount of indigent patients. And that's critical for us that those upstream referrals are available. Much what Trent was saying in his communities, it's the same as in our communities. We need to be able to have those affiliations, but also to, like in my example of the cancer program, the cancer programs in most of our hospitals depend on the 340B program. I would even say that it's so interesting to me that we're talking about this obscure funding program at the federal level that
not even funding, discount program.
When you
think about it,
that hardly anyone knows about.
Mm-hmm.
And almost every hospital that is eligible for the program that uses it, without it, they probably couldn't keep their doors open. I mean, and I've heard that from our urban counterparts as well as our rural counterparts. We take for granted much of the time we take it for granted because we're just ignorant of the program, no matter who it is that we're talking to. But it's a critical thing that helps us extend scarce healthcare dollars to help take care of all the people in our communities that depend on us.
I just want to thank you guys for coming out. And those of you who have been listening to this episode of Inside the 1581, if you want to learn a little bit more about the 340B drug program, I would encourage you to check out what Duncan Health, DRH Health has done on their website, give you some more information. If you want to understand a little bit more about some of the political dynamics around the discrimination that Big Pharma is engaging in, there was an editorial that we authored called Don't Fall for Big Pharma's Claims about a program benefiting Oklahomans. And it was just released today in the Tulsa World. And there will probably be some additional editorials from the hospital community further speaking about the importance and the value of the 340B drug program. So with that, guys, I just want to thank you for being here and joining us. As always, it's a joy to be able to share with the public what's going on and the good work that's going on in hospitals all across the state. And it wouldn't be possible without the folks that put all of this together inside the 1581. And that includes Alex Taylor for making the podcast happen. He edits the stuff that we use for our YouTube channel and also make sure that everything gets posted appropriately on Spotify and the Apple Podcasts. And for Susie Wallace, who's our Vice President of Strategic Communications, she helps to curate everything that we're working on here. And it wouldn't be cool without the great background music by Gunslinger. And we appreciate the use of their song. And for those of you that listen in every weekend inside the 1581, I'm not sure what we got coming up. I think we're going to talk about measles in the next episode after this one. So 7 cases have now been confirmed in the state of Oklahoma, and we're going to talk about what is our state's response and the response from the hospital community on how we're going to address what is a truly preventable disease, measles, which is growing across this country. So until we meet again next week, thank you again for joining us for this episode of Inside the 1581.